And welcome to the 8th Annual Kick Sugar Summit. My name is Jane Steele, and I am joined here today by Dr. Aseem Malhotra, who is an NHS-trained consultant cardiologist, fellow of the Royal College of Physicians, and president of the Public Health Collaboration. Aseem is a world-renowned expert in the prevention, diagnosis, and management of heart disease. He is an honorary council member to the Metabolic Psychiatry Clinic at Stanford University School of Medicine, California. Aseem is also a founding member of Action on Sugar and was the lead campaigner highlighting the harm caused by excess sugar consumption in the United Kingdom, particularly its role in type 2 diabetes and obesity. In 2015, he helped coordinate the Choosing Wisely campaign by the Academy of Medical Royal Colleges as lead author in a British Medical Journal paper to highlight the risks of overuse of medical treatments. The same year, he became the youngest member to be appointed to the Board of Trustees of the UK health think tank, the King's Fund, that advises government on health policy. Aseem is a frequent expert commentator in print and broadcast media, and he has written scores of articles for a number of publications. In 2016, he was named in the Sunday Times Debrett's list as one of the most influential people in science and medicine in the UK in a list that included Professor Stephen Hawking. His first book, co-authored with Donald O'Neill, The Pyoppy Diet, I hope I'm pronouncing that correctly, has become an international bestseller. His second book, The 21-Day Immunity Plan, is a Sunday Times bestseller, and his recently published third book, A Statin-Free Life, is already a bestseller. Award-winning American scientist journalist Gary Tobes describes Aseem as someone who has probably done more in the UK to inject sanity into nutrition science and the pharmaceutical industry debate than any human being alive. This is quite the amazing list of accolades, Aseem, and I'm honored that you've joined us here today on the Kick Sugar Summit. This is your first time here with us, so welcome.
My pleasure, Jane.
Yeah, and maybe
Always happy to share my knowledge and insights and wisdom.
Yeah, no, it's wonderful, and thank you for your contributions to reversing a lot of the negative and misinformation that is out there with practical, cutting-edge, real science and your personal experience. And I'm wondering if we can start there today in our conversation. Sure. Yeah. So, what got you interested in this? I know you're classically trained as a cardiologist, and a lot of what you posit is opposite to what it is that you were taught in medical school. Let's start there.
Yeah, great question. So for me, on a personal level, as a qualified doctor, Jane, my primary motivation is to help my patients, lead healthier lives, better quality lives, and the ultimate purpose of knowledge for me, and I'm sure many people, in fact, probably most of us, if we really think about it, but certainly for doctors, is to reduce human suffering. And everything that I do is focused on that goal. And I qualified as a doctor in 2001 from Edinburgh Medical School. So I've been qualified, well over 20 years now. And the big issues, as you probably know, as most people listening will know, are tackling the chronic disease burden, which is predominantly driven by lifestyle. Obviously, obesity is the tip of that chronic disease burden iceberg, and then my role has been, in many ways, as a clinician, as a clinical cardiologist, is to try and change the narrative to make sure that people are making decisions that are fully informed on all the information, to remove as much as possible commercial invested interest from information that people receive, so that they can actually get to that goal of leading the healthiest lives they possibly can. So that's really what I'm about and what I've been working on for certainly at least the last decade as a proactive public health campaigner.
Yeah, amazing. And your role with the Public Health Collaboration, can you say more? For many of our listeners are in North America and may not have heard of this organization.
Yeah. So it's essentially a grassroots organization, Jane. I'm the president of the Scientific Advisory Committee of that organization, a charity. And it was set up several years ago. The original founder, the person that coordinated and got people together, is a chap called Sam Feltham. He's a director. And what we are made up of, essentially a grassroots organization made up of doctors, patients, members of the public, allied healthcare professionals, including dietitians, nutritionists, nurses, health coaches, for that purpose of trying to improve population health and advocating for exactly the kind of things I've been mentioning. So informing healthy decisions, and also, of course, not ignoring really important policy changes that are going to help the population in terms of curbing obesity. And then linked to that as well is better transparent information. I know we're going to talk about this briefly soon, is about better transparent information when it comes to drug prescription, because linked to the obesity epidemic or the lifestyle chronic disease epidemic is overprescription of medications. And what we need to do on a bigger scale is shift the balance where the primary step in someone improving their health is going to be lifestyle related, with medications as a backup. At the moment, we've got medications that have very marginal benefits at best for chronic disease management, which come with side effects, while ignoring the lifestyle changes. So everything's upside down, and that's what we need to change. So the public health collaboration really are a force of, about 500 at the moment. I would say an army of doctors and members of the public and patients who want to, facilitate that change.
Beautiful. And can you say a bit more about what those main changes are when it comes to lifestyle and the food guide, sugar, cholesterol, all of these components?
Yeah, absolutely. So just before I answer that question, I think you mentioned earlier around, one of the things I'm known for is busting myths and changing narratives on things. Yes. And I've done that predominantly through medical journal articles that got a lot of attention, whether it's about understanding how heart disease develops, but also its prevention and its management and even potential reversal. From that to busting the myth, of physical inactivity and obesity. So I've been involved in all those things, and one of the concepts that people need to really which I think most of the public don't fully appreciate still, is that medicine is not an exact science like, say, physics or chemistry. It's an applied science it's an art as much as it is, based upon scientific principles. But the reason that I say that's important to understand is because it evolves. We were taught at medical school that 50% of what you learn during your training will turn out to be either outdated or dead wrong within 5 years of your graduation. The trouble is nobody can tell you which half. You have to learn on your own. And that's really important, because people have this false perception of that if it's a truth in medical science or in medicine, then it remains an absolute truth forever. And nothing could be further from the truth. So people have to have that element of being open that things. So today's truth is tomorrow's folly. Yeah. And that's where, for example, a lot of people still are have a exaggerated fear, for example, of cholesterol and heart disease, don't understand the nuances of it. And therefore, there is still this big drive to reduce people's cholesterol either through diet or drugs, despite the fact that the evidence suggesting that's of any benefit is very, to put it politely, unclear. To put it in a stronger terms, is basically a nonsense, right? So, and those are things that we need to counter. And one of the reasons why this flawed science persists is because there are very powerful vested interests, big companies, that make money off a false narrative. Yeah. And therefore changing that, evolving that so that everybody knows things have changed and there should be a different approach, is a battle. And it's going to take a lot longer than it otherwise would, because of the fact that, the food industry and the pharmaceutical industry make, billions of dollars, pounds, whatever you want to call it, from a fear of cholesterol.
Yes, it's incredible. And your book, Statin-Free Life, does that go into exactly what you talked about?
It does, and if people want to read in a bit more detail, and it's not a long read, I can be quite precise with it, then that kind of talks about cholesterol, it talks about statins and their benefits, and which are, again, a lot more modest than people are led to believe. And that's important because it then changes the decision-making process. Rather than a black and white, your cholesterol high, take a statin, and walk around thinking, 1, oh, I'm worried my cholesterol's high, 2, I'm doing something about it. When in fact, what you're doing about it isn't really going to have much of an impact on you, but it's important to be transparent with people about that. So yeah, the book covers a lot of those areas.
Yes, wonderful. And
but I haven't answered your question. So the question is, what should we be doing? It's not rocket science, Jane, actually. The implementation is the hard part, and I'll explain why that is. But really, it's about just following a nutritious diet, moderate activity, not being sedentary, getting a good sleep, and keeping stress levels in check. And if you do that, potentially we would curb or combat or eradicate. Of course, smoking also is an issue in developing countries more than developed countries too. You'd already eradicate 80% of heart disease, which is still one of the biggest killers in the Western world. It's certainly the biggest cause of premature death in European men. So it's a big issue still. And this is the primary approach to resolving or sorting heart disease out. And the way it's linked to obesity is one of the hypotheses, which I think has a lot of validity, is that our obesity epidemic coincided with a national campaign and focus, government campaign supported by public health agencies and authoritative scientists to lower people's cholesterol, which meant that the food industry created a lot of low-fat, high-sugar foods.
Yep.
And that is certainly now pretty much, as best evidence as we can get, likely causal factor in driving obesity and type 2 diabetes, which are themselves risk factors for heart disease as well.
Yeah, beautifully
so we
said.
haven't really curbed heart disease from those interventions, and yet we've made cardiovascular risk worse because of flawed science, which is quite extraordinary if you think about it.
It's amazing that that if we do the opposite of what we're taught to do, that we end up with really good health, which is, I think, outlined in your book. It's really paradoxical. So, can you do a broad stroke of what you've written about as being a healthy diet?
Yeah. So, just for perspective purposes, in terms of the hierarchy right now of what's influencing chronic disease, poor diet is responsible for more disease, chronic disease and death, than being inactive, smoking, and alcohol combined.
Amazing.
So diet is really one of the most important that we should be focused on, I would say. And then what would constitute a healthy diet? So I think if one looks at the biological processes that are driving certainly heart disease, but many other conditions, type 2 diabetes, high blood pressure, and probably even cancer and dementia, we talk about something called insulin resistance, which is your body becoming resistant to the hormone insulin over time. And insulin has many roles to play, including fat storage, even building muscle. But in chronically high insulin over time is a driver of heart disease and many other chronic diseases. So what's driving that chronically raised insulin, or what's driving resistance of the cells to insulin? And when it comes to diet, the specific big culprits really are sugar and refined carbohydrates. Also, what I would say is ultra-processed foods, a combination of foods that are designed to be hyper-palatable, potentially addictive, depending on your predisposition. Mm-hmm. And what they do is, and that combines sugar and fat and carbs, for example, is that they have the biggest impact on blood glucose responses and blood insulin. And if you're doing this on a regular basis, say 3 times a day, that is going to set you up for these problems later on in life. So what do we do? Well, removing or minimizing certain of those foods is a good start.
Yeah.
And then it's about making sure that you're getting, as much of your nutritional requirements as you can. In fact, you can get pretty much all of your nutritional requirements from a healthy diet, which avoids needing supplements, is really just eating nutritious food that's is designed to nourish you and make you feel full. And if people did that, from childhood, then in general, those people are not going to get particularly overweight or obese. I think one of the interesting things to throw in there is what we call a confounding factor or a contributing factor, which I've become much more aware of in the last few years, is chronic societal stress. Mm-hmm. And we've all been in that position, Jane. Like, you are more likely to reach for the comfort foods, for the highly palatable, sugary foods if you're stressed out or if you're feeling low, right? It's a pick-me-up. Because sugar, has that impact on the brain on dopamine, yes. And that's that is, so if we've got a baseline chronic increased levels of stress in society, that is also likely to drive that type of behavior that's going to lead to excessive consumption of unhealthy foods. And you combine that with a food environment that's saturated, an oversupply of sugary, cheap, ultra-processed foods, yeah. Which means it's almost impossible to avoid them. And, most people, I think, don't appreciate that their choices when it comes to food and many other things are structured by forces that are beyond their immediate control. So one analogy would be, it's like people keep talking about education and personal responsibility.
but it's like asking a child that grows up in a sweet shop to not eat sweets, right?
Yes.
So to curb this problem on the larger scale, the biggest impact is going to be environmental. We can educate ourselves as, for constantly being told these messages that it's about personal responsibility, you can get, and people can, but they're more likely to relapse if the environment is working against them. And one of the comparisons I make, which I've been making, is to big tobacco industry. So, people have short memories, people forget history, and the biggest impact on curbing tobacco consumption, certainly in England, in the UK, about 50% of people were smoking in the 70s to about 17% now, massive reduction. The single biggest intervention was an environmental intervention on tobacco. It wasn't through personal responsibility. Of course, that's important. Educating people is crucial. But the biggest intervention was taxation of cigarettes.
Yeah.
So when we think about even food addiction or helping people, we want to make sure that we're trying to create an environment that they live in and even work in. You go to hospitals and it's saturated with junk food, that is conducive to them leading healthy lives. And that even applies to stress. I know we're going off on a tangent slightly, but if you are in a low control, low pay, high demand job, the levels of stress that exerts on you is effectively, it's a death sentence.
Yes.
Right. And that is also another big issue going on with society right now, is that many people are on these kind of jobs, which is not just, while these big corporations, the CEO differential in terms of their pay compared to production worker is often equivalent to 200 to 300 times more. And we have these widening gaps in equality in society. And that also, interestingly, Jane, links to obesity. So the bigger the more unequal societies in terms of wealth, the more chronic disease, the less community spirit, the more it generates feelings of superiority and inferiority, the more status anxiety, which also drives mental health and physical health problems. So we have to, what I try and do is go to root cause and really look at the whole picture together. And I think empowering people with that bit of knowledge ultimately will help encourage policy changes or law changes or societal changes that are going to be to the benefit of everybody.
Yes, agreed. I've heard that in the States in particular, that there are huge neighborhoods that don't have grocery stores, that the only option is fast food and convenience stores, because that's what the population wants, is the narrative that's trotted out there. And it becomes this chicken and egg thing, as you said, the environment and marginalization, poverty. It's a big problem. And you mentioned a little bit back there about addiction, and why is it so difficult? Well, if there's no other choice, and that's what you're presented with, and if it's what's cheap and what's available and what tastes good, we're really set up to fail, aren't we?
Yeah, especially if your life's otherwise, if you're not being valued in your work life or in your relationships, or you're not involved in the community, then this is kind of that comfort, that quick fix. It's like, and also many people can't necessarily afford. It's much cheaper, these sorts of foods. So it's kind of insulting to certain demographics of people to say, just quit ultra processed food and eat healthy food, because they aren't being paid well enough to be able to actually enjoy healthy food on a regular basis.
Exactly.
So that's where government intervention has to be there, for sure.
Yes, absolutely. And this is where your work is so important, Aseem, really being that voice out there in multiple ways, being here today, doing the writing and all the rest of it. If we can switch gears a little bit, I'm curious about your personal experience with addiction. I know when we met at the PHC conference in Bristol a few months ago, you were telling me a tragic story about your mother. Can you say more about,
Yeah, so even before talking about my mother, so I grew up in a household, which was again linked to my mother's food habits, if you like, which was just full of sugar. Okay. I come from North India. India is the largest, producer of sugar in the world. It's part of the culture, to have sugar pretty regularly. Certainly it's, if you go to a temple to pray, you'll be given, the food that's provided for the community or the people that come there is often a sugary food.
Yeah.
So Indians are particularly vulnerable to sugar consumption. And I certainly grew up, when I reflect now, Jane, I was consuming a lot of sugar. I mean, I'd have sugared cereal for breakfast. When I went to school, I would, mid-morning, I'd be hungry. I thought this was normal, by the way. So after, even before lunchtime, within a couple of hours, I'm really hungry again. Then I'd have a candy bar, chocolate bar, with some potato chips. It comes to lunchtime, I'd have my usual lunch, and then I'd have dessert with lunch. I'd probably have another snack mid-afternoon. And then when I was a junior doctor, I was doing exactly the same thing. And I calculated that probably in my first, certainly up to the age of 30 or so, I was probably consuming about, in total, in terms of all the foods where the sugar is added, probably about 40 teaspoons of sugar a day. And I craved it, and I loved it, and I would, eat ice cream several times a week, etc. The only thing although I know I've been involved in, this myth, plus that, you can't outrun a bad diet, and certainly that is more of an issue as you get older. But I was extremely active as a sportsman, so it probably didn't show as much on me. Although I always had that little bit of belly fat, which I couldn't get rid of. So for me, that was where I would say I'm a reformed sugar addict for sure.
Yeah.
And then my mum as well, she was a doctor, general practitioner. She loved these treats, and our fridge was always full of, she'd bring them for me basically, right? So there was always some treat for me in the fridge, whether it was chocolate cake or a donut or a jam donut, and so I grew up in that kind of environment. And my mum would eat a lot of that stuff. She loved that food. And she suffered, unfortunately, into middle age. She had high blood pressure. She was considerably overweight, probably in the obese category. And then suffered a brain bleed because of high blood pressure, and then recovered from that. And then towards the end, she developed rheumatoid arthritis. And I'm sure all of these things certainly played a role, absolutely, without any shadow of a doubt. She was also vegetarian, but vegetarian, which is much more on the starch and the refined carb side.
Yes.
And again, probably protein deficient as well. And with her rheumatoid, then muscle mass gradually also rapidly declined. So, when she died prematurely at 68, she was so frail that she had an infection in her spine called discitis, and antibiotics couldn't do anything. She was in awful pain. I mean, the morphine doses were not even enough to curb the pain. And then she went into a coma and died. So it was all very, very awful.
Wow.
But I think that her lifestyle unwittingly had a big role to play, unfortunately, in her health problems. And for me, any suffering, we all suffer in life. I think one of the keys to deal with suffering, which is part of life, is to try and turn it into something positive. So I wrote about it, and it became a big story in one of the newspapers here. And then linked to that, because we haven't really curbed the problem of chronic disease and obesity related illness, Jane, our healthcare systems are under so much pressure that when she was finally admitted to hospital, they even weren't able to manage her in a way that would relieve her suffering to the optimal level. So a heart attack was missed. They were too busy to treat her when she went into something called pulmonary edema, when her lungs were flooded with fluid because of the small heart attack she suffered. And it took hours before treatment was given. So all of these things, when you experience that, we're all going to go at some point, but we want our suffering to be minimized. And the healthcare system is so bad now because we haven't dealt with the prevention side. And we're again using medications which, are largely useless. Let's be honest, right? Many of these medications for chronic disease are largely not very effective. Most people don't benefit, let's put it that way. And they don't improve the quality of your life. For me, there's some very, very clear explanations as to why we have this healthcare crisis. And the two biggest culprits that I've been campaigning on to highlight the harms that they cause are the food industry and the pharmaceutical industry.
Yes, exactly. My gosh. I'm so sorry to hear that, Aseem. Yeah. And so for you, being brought up in that environment, and eating all that sugar, what helped you turn that around? I mean, I'm assuming you have turned that around.
So I think once I started to, so I think the first motivation for me always comes back to my patients. So I was seeing this increasing burden of chronic disease on a visceral level at the front line in hospitals and clinics, managing heart attacks. And I could see more people coming on multiple medications, more miserable over a time period, over a decade since I qualified in 2001. And then I started to look into the obesity side. And on a personal level, I suppose I've always been a foodie. I learned to cook when I was 16. You know, my dad taught me to cook, and you know, I loved eating nutritious food. Although I was also eating these treats on top of it, most of my meals were still, you know, the base of my meals were good, healthy meals. So I had my personal interest in that, and then I looked at the hospital food environment, and I started looking into what was causing this obesity. I started researching it and realizing that dietary changes. One paper in the European Heart Journal, if I remember correctly, you know, suggested that the impact of dietary change on risk factors for heart disease was rapid within a few weeks to months, which was extraordinary. So that's got me thinking into the diet side. And then when I went further into the research, I think sugar came onto my radar initially because of Professor Robert Lustig, who's become a very good friend of mine. So he's a pediatrician in California, and he wrote an editorial in Nature, and he did a lecture in University of California, San Francisco, which was, I think, Sugar, the Bitter Truth, and it's got millions of views, and it was fascinating. He explained all of the ways that sugar was causing harm, and then I started doing my own research on it, and it all started to fit and make sense. And then wrote some papers in the BMJ, highlighting the fact that, you know, we weren't following the up-to-date science at that point in terms of sugar's harm. You know, American Heart Association 2009 suggested that the limit for the average American male should be no more than, you know, 9 teaspoons of sugar a day. For a female, 6 teaspoons, and for a child who's 4 to 8 should be no more than 3. Yet the average American and the average Brit was consuming probably at least 20 teaspoons of sugar. Yeah. So I tried to figure out what was going on, and it led me down a rabbit hole of huge commercial conflicts of interest, collusion, if you like, between food industry and, you know, guideline boards, science, nutrition scientists, that was then contributing to the misinformation on healthy diets and probably driving the obesity epidemic. So that's how I, you know, but with sugar, it was Robert Lustig for sure initially that gauged my interest, and then I started doing my own research.
Yes. Okay. So it was largely coming from information for you, and then seeing the results and linking it all together.
And seeing my patients, and then, you know, applying that, and then learning as I go along, to become, you know, keep myself up to date, but also implement in a safe way with patients these lifestyle changes. And then when you see the results, Jane, they're extraordinary. You know, yes. People coming off blood pressure pills, people turning their type 2 diabetes into remission. So you know that what appears to be true from the data, or at least relatively true, is actually working in real world practice, and that's great. There's no greater feeling as a doctor to see your patients get better.
And how do you transmit that information to them in a way that motivates them to go through the withdrawal, break the habits, when we are in this environment of food pushing and you know, carbs are good for you and all of this kind of thing?
So it's a great question, Jane. And I think I, again, have evolved my approach to this over time. Initially, like with smoking, I know different people need different interventions. Okay, so we know that there are behavioral interventions, environmental interventions, abstinence. My initial approach was an abstinence one. So I would explain to patients first, help them understand rather than dictate to them. It's important they're empowered with the information so they understand why they're doing something, what benefits are going to happen, and come back to me and let's see how you're getting on, right? So that's really important, I think, in medicine. I try to be very engaging with my patients. I want them to be empowered with the knowledge as well, rather than just following doctor's orders, right? Because I think it's more likely they're going to sustain it if they understand it. So I would always go for a cold turkey approach with sugar. That's what I did. Yeah. And it worked for me. And I also tell them that usually the cravings for sugar do start to change within a few weeks. Yes. So you adjust your palate. And, you know, if people say, well, how am I going to live? It's like, well, listen, have you got the willpower to get through this for 21 days? And then maybe 6 weeks, and then let's have a conversation. And often they'll come back and say, listen, it's so different. I'm not craving sugar anymore. I'm enjoying this diet. And by the way, I've also lost weight. You know, people get happy about that. I've not counted calories. So that's the way I used to approach it with my patients, Jane. Wasn't very intricate. Yes. I think, though, certainly with my cardiac patients, where there's a multifaceted approach where I talk about the foods they should be eating, the moderate activities there, but the missing link, I think, in conventional practice is dealing with stress properly. Yes. And invariably, most of my cardiac patients have very high levels of stress. People have suddenly suffered a heart attack. You go through the history and you say, well, how much stress have you had? And you try and get a crude measure of their stress on a scale of, say, 0 to 10. and almost always it's above 7 or 8 and often 9 or 10.
Mm.
And we know that stress triggers the kind of inflammatory responses that are and the changes in blood linked to clotting that are linked to heart disease development. And there is some data, it's not the highest quality data, but there is some data on heart disease reversal that showed that, say, for example, 40 minutes of meditation a day was the single most important factor in that intervention.
Mm-hmm.
So I do it from a perspective of heart disease, I do it from a quality of life perspective, and I do it from a perspective that they're more likely to sustain the healthier diet if their stress levels are curbed. And therefore, I always try and get other people involved, like a meditation teacher, a cardiac nurse. I talk about in my book, who's been amazing with my patients. And of course, there are health coaches as well, where people need that extra bit of help. And I think we shouldn't ignore that. I think they have a very important role to play. But I will maximize whatever I can do in that one consultation when it's just me and the patient.
Yeah.
And what I do is I tell them to go cold turkey. And I tell them, say, see what happens to you in a month. Just give it a go. Can you do it? And most people, they're like, oh, I can do a month, doc. This isn't. Yeah. They often have this idea that's going to take. They become overweight or obese over years. It's going to take years to reverse it. And I tell them that's not true. Mm-hmm. And this, you can achieve, for example, with type 2 diabetes remission, if people go low carb, the peak effect certainly is up to 3 months. So you're going to see that effect within 6 weeks to 3 months, maximum effect that you'll get. But you have to go cold turkey to see how far you can go. Yes. And that's what I do with my patients.
Oh, that's beautiful. And is the cold turkey approach effective because you're not continuously re-stimulating that whole dopamine reward system?
I think so. I think so. And I think in terms of addiction, and I know you know a lot about this, Jane, I think there are other substances that are much harder to go cold turkey on, okay? In general, when people talk about addiction, whether it's drugs or alcohol or whatever, cocaine, I think, and people may disagree with me, I'm sure someone's going to come and say, no, I find it much more difficult to quit sugar than cocaine. But I think that in general, although there is that addiction there, it's not like people are having convulsions.
Right.
If they go cold turkey on sugar.
Yes. Well, it's not dangerous per se. It's
not dangerous to go cold turkey, right? That's what absolutely. And I think also it's in some ways probably easier to quit sugar than other substances of abuse. Right. So I think certainly easier than alcohol, for sure. Right. So I think it's safe to do, and I think it's easier. It doesn't mean it's easy.
Yes.
It's easier. Yeah. And that's why I say go cold turkey. And of course, I think if people have a big component where there's a psychological element to it,
yes,
then it's not going to be that easy just to say go cold turkey. That's where I often have to assess, do they need a psychological intervention as well, as in a specialist? Not just about meditation. Do they need a specialist to speak to about other things that are going on that are probably the roots of some of these behaviors?
Yes, absolutely. So it is a complex, multifaceted, and
it is complex, multifaceted. But I think for the majority of people in this country, in the US, who have a mild addiction to sugar or cravings for sugar, you can literally just do a very safe, cheap, effective approach, go cold turkey.
Beautiful. And
without any other intervention, and you will get there.
That's really encouraging. Yeah. So I know you have the 21-day immunity plan and the PIOPI diet. Can you say more about when people are taking something away, what would they be replacing it with? Is that outlined there? And can you speak to that?
Steak.
Aha. Excellent. In a word.
Healthy. So I'm a big foodie, right? So I think one of the reasons why I was also a bit of a sugar addict, because we all like sensual pleasures, okay? That we're sensual beings in many different ways, and one of those pleasures is food, right? So it has to be, for me, I don't like eating bland food. I'm very much into, I cook Mediterranean food and Indian food. So I think it's a really good question you ask. I think it's important to tell people, by the way, although you're taking away something that you think is very pleasurable for you, you're going to be eating equally pleasurable food and healthy too, right? Which is a great combination. And I think it's good. It's important for people to get into that mindset that, people don't think it's just a bland salad, right? Yeah. That's my meal. And unfortunately, it doesn't have to be. Of course, salad can be nice, but you are eating some really good stuff like meat and vegetables. If you're a meat eater, of course, as a vegetarian, then there's lots of amazingly nutritious, tasty vegetarian foods you can eat too. With the right kind of seasoning, etc. So you are basically eating just whole foods, Jane,
Yes.
anything that's a whole food, really.
Yeah. 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 It's not
Anything
rocket
that's a whole food.
science.
Yeah.
Yes. And learning to cook, would you say, is that a big part of what you recommend for people as well?
Yeah, if they have I mean, learning to cook itself, I think it has to kind of come from within.
Hmm.
Um, uh, if they have to be motivated, because it is a bit time consuming compared to, say, for example, buying fast food or whatever else. It does take a bit more time. I do think that I can tell patients that I think the way to get people cooking more is to go back to school. So one of
Right.
the things I campaigned on with Jamie Oliver many years ago when I started my campaigning and became a public figure in the media on this stuff was actually, a letter we wrote to the Prime Minister. It became headline BBC News. So I coordinated a letter that was written to the Prime Minister, basically saying that we should have compulsory nutrition education and cooking skills introduced into all schools in
Mm.
primary school. In like people, kids by the time they reach 11 should have some basic knowledge in food and nutrition, but even cooking skills, because it's a skill for life. So I think that's a cultural change needs to happen across society for that, I
Yeah.
think.
Yes. Agreed.
Because
Yes.
I remember a statistic, if I'm not wrong, that 50% of Americans don't cook or don't know how to cook.
Yeah.
50% of
Yes.
American adults. I mean, that's extraordinary, isn't it? And it didn't used to be that way. You go
That's
back
it.
to the 60s, 70s, 80s, I'm sure it was, not even close to that. I mean, it must have been a very small minority of people that were in that position.
Yeah. Yeah.
So I think that we need to go back to those basics.
Yeah. Yeah.
And
Exactly.
it's fun too. I find it very relaxing. I enjoy cooking. I like eating my own food that I've cooked and prepared, and I know what I'm putting in as well. I know where I've got my ingredients from, what's in my food.
Yeah, yeah. So making it into another part of the lifestyle and hobby. I know Dr.
Yeah,
Robert Lustig talks about that a lot. Let's bring community back in. Let's bring some joy, collaboration, fun, make
absolutely.
activity. Yeah, absolutely. I do have a question again, arcing back to the cardiology component for people who have done some damage to their arteries through, decades potentially of inflammation harm to do with diet and lifestyle. Can that be reversed by going to a whole foods diet and eating more saturated fats and or are people stuck with it? Will they start to cut
Yeah, it's
themselves
a
out?
great question, Jane, and
Yeah.
it's a controversial area still. If I'm being a pure scientist looking at it,
Yeah.
but there is data. There's certainly anecdotal data. There is some published data showing that reversal process happens.
Okay.
The question we don't fully know for sure is what is the most likely mechanism behind that in terms of what intervention, but we can make some very reasonable postulations of what it is. And again, it comes back to counteracting the twin evils of heart disease, which are insulin resistance and chronic inflammation, through a
Yes.
dietary approach. The best evidence we have on heart disease reversal comes from India. An interventional cardiologist there put a number of, several hundred patients who had moderate to severe heart disease, so blockages that were at least 50 to 70% of their arteries. They didn't want to undergo any stenting or bypasses, for example. And he put them on a healthy lifestyle plan. And that lifestyle plan in India, in this particular case, was a very high fiber vegetarian diet. It was 2 30-minute brisk walks a day. And it was something called Raj Yoga meditation, which was 40 minutes of meditation, but also it was like a family intervention, getting the family involved. What's driving stress? Let's just think a little bit more compassionately towards each other. All of those things, like a kind of shift in the lifestyle in terms of managing stress and dealing with the relationships as well.
Yeah.
And when they did the analyses, so first of all, he followed these patients up over a number of years and repeated their angiograms. And the people that had adhered through the questionnaires to the full lifestyle protocol, the best, had an average reduction, which is still quite extraordinary, of 20% reduction in the narrowing of their arteries, which is unheard of, right? It's if you ask most cardiologists, it's possible, saying this is nonsense, not possible. But that's what the results showed. And then further analysis looked at what was the single most important factor that was responsible for that. And it was 40 minutes of meditation per day. It superseded the diet and exercise massively. Once they got that right, of course, I'm not saying that you ignore that. No, the diet has to be right. But then what is going to stop you from, say, progressing heart disease slowly versus reversal? And that extra intervention could well be stress reduction and meditation.
Interesting. Wow.
So I'm doing more work on that. I'm implementing this with my patients. I'm having protocols with them. I'm following them up with a year with certain imaging that's non-invasive and safe that can look at correlations of heart disease. We call it calcium score. So I'm doing that proactively with my patients.
Yes.
So, you know, if people are interested to learn more about it or whatever else, then of course they can find me online and get in touch. And but I'm gathering data on that, and hopefully, you know, we'll publish something at some point. We ideally need a good trial to show that, but I think that it's the way forward. Yeah, heart disease reversal is my thing. That's my area of interest now.
Yes, yes, absolutely. And I'm curious on that note, is it the coronary artery calcium test that is
Yes.
the gold standard for measuring is someone
It's not.
or
The gold standard is actually an invasive test called a coronary angiogram. So this is what I train to do. You pass tubes up to the heart under local anesthetic, and you inject dye, and you can see the arteries.
okay.
The calcium score is a very reliable correlate. It's not
Yes.
absolute, but it usually correlates with the degree of furring of the arteries. So 0 is like a perfect normal score, and over 1,000 is severe, likely severe heart disease. But you then need confirmation with an angiogram. But a calcium score is non-invasive, takes a few minutes, very little radiation, so it's quite simple to perform and safe, and in the right patients is useful. But that's why it's important to understand, like, what's the age of the patient? Have they got symptoms? Because it may be an inappropriate test for some people. They may need something else.
Okay, interesting.
Very useful. Yeah.
And can you just say a bit more about that? Because again, there's so many people really concerned about high cholesterol and, you know, clogging of the veins and all that, whereas the simple test could rule out that fear and worry for people, or confirm it, and then hopefully give them more motivation.
Sure.
So is it?
The test is also a snapshot. So that's why you see. So I think, Jane, what's important is that there's a lot of, you know, one of my concerns with the way medicine is going, and certainly I got this experience more in the States, is we're shifting away from what it actually means to be a good doctor.
Okay.
And this is also part of the problem, because we're relying on tests more than actually talking to the patient. You know, we were taught in medical school, and this is still true, 80% of your diagnosis comes from the conversation, if you do it properly, right? It has to be tailored to that individual. So what I would say is that in general terms, a calcium score is a useful additional tool, but again, being used in the right patient.
Okay.
And having that conversation with the patient. So what are their risk factors? You can do some crude calculations of what their risk of heart disease, heart attack or stroke is in the next 10 years. From that, you can then have a conversation with them, for example, whether a statin might benefit them slightly or a lot or not at all. And the calcium score can be part of that. So I think that's a crucial thing. Rather than just people doing tests on their own, I think it's important that, the two most important bits of without digressing too much, of a successful patient outcome for a doctor is their clinical knowledge. Their knowledge has to be good. It's really important. A lot of people rely on tests and don't know how to interpret them. And then it drives fear and anxiety, and it drives over medication, right? So the clinical knowledge is really important, right? And then empathy. Do you really listen to your patient? Because and also that's linked. If you're empathetic, you'll get more information from the patient that's going to be relevant to improving their outcome.
Yes.
And my concern is reliance of tests before you've even had a conversation with the patient is very bad medicine and drives unnecessary fear, anxieties. People don't know how to interpret them. It all has to be contextualized with a patient.
Okay.
But to answer your question, though, in people with very high cholesterol, the calcium score can be very useful, where if they've had cholesterol that's been very high for most of their life, which, by the way, most of your cholesterol is genetic, right? So your LDL, the so-called bad cholesterol, total cholesterol is genetic. You can influence the cholesterol profile of our diet significantly, but the absolute total numbers are mainly genetic. Then what happens is, let's just give an example. Say a lady, for example, comes to see me in her mid-50s. For the first time, she's been scared to death by her doctor that her cholesterol is sky high, in a level that only represents 1 in 200 of the population because it's so high, and being told you must lower your cholesterol, otherwise you could die, and go on a statin or go on a cholesterol-lowering drug. The logic at that stage in these patients is this, and I talk to these patients, say, listen, you've had this very high cholesterol likely for all of your life. If it's a problem for you, you're going to already have some degree of heart disease. How can we exclude that? a calcium score can be used.
Yeah.
And often these people, by the way, that come to me who are middle-aged females are super healthy. Their metabolic health is perfect. They haven't got high blood pressure. They're not pre-diabetic. They're not overweight. They've got a normal waist circumference. Their triglycerides and HDL, which is actually more important part of the cholesterol profile, is great. And more often than not, Jane, in these people they've been told they've got familial hyperlipidemia or genetically high cholesterol, you do a calcium score, something a little bit more invasive often, which is called a CT coronary angiogram. It's completely normal. And I can go back to them and say, listen, for you, cholesterol isn't a problem. There's no indication for cholesterol-lowering drugs. In my view, your coronary arteries are clear. Go and enjoy yourself.
Yeah. Beautiful.
Keep enjoying yourself.
Yes. Yes. Wonderful. Thank you. Thank you for that. And where can people find doctors who practice like you, as opposed to people who have done the critical thought? Is there a...
it's called Queen Anne Street, and it's in London, and that's where I'm at now. Jane, to be honest, I get asked that question quite a lot. I think that I'm obviously, through my work and through my writing and trying to influence cardiology practice over the years, and I've published on this stuff. I push whatever I do, I push that out, and say this is how we should be doing things. I honestly, they're few and far between. In Australia, the closest person to me who's a good friend, he's a great cardiologist, is a guy called Ross Walker. I'm not aware of many people in the States that do things the way I do. Okay. I think the closest person probably would be Brett Scher, who writes for Diet Doctor.
Yes.
But in terms of the statin approach, I'm probably one of the only cardiologists in the world that does that, I think, as far as I'm aware.
Okay. Yeah.
But it's also about informing the patient in absolute terms. It's not saying don't take it, but I break down the data in a way they can understand that is in keeping with ethical, evidence-based medical practice and informed consent. And then whatever they decide, I support their decision, right? If they decide, as long as they understand what I'm telling them, I support them if they want to take a statin or whether they don't. And I document that. And that's helpful for them because they can then go back to their family practitioner, who often are fearful because they don't have the full information. And they've then got a specialist who has an expertise in this area, that then they all say, oh, okay, I'm going to back off now. Okay, fine. I get it. Thank you. So a lot of doctors, unfortunately, aren't, and that's not their fault. They're so busy, are not up to date with the evidence on these things. And as I said, if the guideline boards often who are very heavily conflicted, the huge financial incentive to prescribe statins, they are not necessarily going to be giving that information in such a granular way in their recommendations. And then, of course, in certain healthcare systems in the US, for example, doctors are often paid by more tests they order or more drugs they prescribe, right? Yeah. So there's a huge bias there. And I don't have that. That's not, that isn't something I have to worry about. So I can be absolutely, and that's how doctors should be. We shouldn't be having this conversation. I mean, patients expect their doctors, they want to trust their doctors to give them honest, complete information and not to be influenced by prescribing drugs or organizing tests for them so they can make money out of it.
Yes, agreed.
As far as I'm concerned, that's not medicine.
Yeah. That's
marketing. It's not. You're seeing a salesman. You're not seeing a doctor.
Yes. Yeah. Well said. Yeah. So your book, A Statin-Free Life: A Revolutionary Life Plan for, I've written it down here, for tackling heart disease without the use of statins. That would be a good place for people to start educating themselves.
Absolutely.
Yeah.
I cover cholesterol. I explain insulin resistance. There's a plan. There's a lifestyle plan in there. There's even some recipes as well if people are interested in that, to see what kind of stuff I eat and what, so there's all that. And it's not a long read as well. I've made it quite concise and quite easy to read. So you could probably get through it probably in 3 to 4 hours easily. And chapters, calcium scores are in, cholesterol, familial hyperlipidemia. I've gone through pretty much all of that data to explain it all. The effects of drugs, exact benefits of them for individuals, all that kind of thing.
Yes, beautiful. And you did mention Brett Scher, who's the director, I think, of dietdoctor.com.
Medical director of dietdoctor.com, yeah.
That's right. I've looked online.
I think he's in, he's based in San Diego.
Yes,
yeah.
Wonderful.
I mean, the other thing is I also do Zoom, stuff. So I get a lot of international patients because I do Zoom consultations. So that helps, a lot of people.
Yes. Absolutely. Okay, wonderful. And where's the best place for people to find you if they want to contact you?
Yeah, if you just my website, Jane. So it's draseem.com. DOCTOR, one word, ASEEM, draseem.com. And then on social media, I'm on Twitter, Dr. Aseem Malhotra, Facebook, Instagram, I'm Lifestyle Medicine Doctor. So that's where people can see a bit of my advocacy and social media stuff. But my website, yeah, they can contact me through my website.
Perfect. Thank you. And we've run out of time. I could talk to you all day, but we'll definitely be inviting you back next year for part 2. Thank you so much.
I hope that's been helpful, Jane. Thank you.
It has. Thank you again.
We hope you enjoyed this interview. And before you